Let's talk about infective endocarditis. Infective endocarditis is a serious infection of endocardium of the heart, particularly the heart walls, and is associated with high degree of illness and death. The prototype lesion of infective endocarditis is a vegetation, which is very important, which is a mass of platelets, fibrin, microorganism, and scant inflammatory cells. So the vegetation, it consists of platelets, fibrin, microorganism, and scant inflammatory cells. The analogous process involving AV shunts, arterial shunts, that is PDA, or coarctation of aorta is called as infective endocarditis. Coming to classification according to temporal evolution of disease, acute endocarditis. It is a hectically febrile illness that rapidly damages the cardiac structures, seeds extracardiac sites, and if untreated, progresses to death within weeks. Subacute endocarditis follows an indolent course. It causes structural cardiac damage only slowly, rarely metastasizes, gradually progressive unless complicated by a major embolic event. Classification according to involvement of walls, that is native wall endocarditis and prosthetic wall endocarditis. Early prosthetic wall endocarditis is endocarditis arising within 2 months of wall surgery. Late prosthetic wall endocarditis is endocarditis arising after 12 months after surgery. Classification according to culture results. Culture positive infective endocarditis most commonly caused due to Streptococcus viridans, Staphylococcus aureus, Staphylococcus galloliticus, and Enterococci. The culture negative infective endocarditis most commonly due to Hassek group of organism, Coxiella burnetii, Bartonella species, Trypanosoma vipili, Corynebacterium species. So all these organisms cause culture negative infective endocarditis. So healthcare associated infective endocarditis, it includes nosocomial infective endocarditis as well as infective endocarditis arising from community after a recent hospitalization or as a direct consequence of long-term indwelling catheters such as central venous lines and hemodialysis catheters. The most common organism involved in healthcare associated or nosocomial infective endocarditis is Staphylococcus aureus, coagulase negative staph, and Enterococci. So these organisms and definition is very important. So coming to the clinical features of infective endocarditis, first is cardiac manifestation. Very important is CCF, congestive heart failure, which occurs in 30 to 40% of the patients. Occurs as a consequence of wall dysfunction or occasionally intracardiac fistulae. There can be perivalvular abscess, there can be heart block, there can be murmurs. New worsened or regurgitated murmur due to valvular damage and ruptured chordae. A changing murmur is a characteristic of infective endocarditis. The murmur which keeps on changing due to the damage to the valve. The non-cardiac manifestations are fever, chills and sweating, anorexia, weight loss and malaise, myalgia, arthralgia, back pain, arterial emboli, splenomegaly, clubbing and petechiae. The neurological complications include septic or purulent meningitis, intracranial hemorrhage, seizures. Renal complications include hypocomplementemic glomerulonephritis, embolic renal infarcts like flank pain and hematuria. So these are the Janway lesions. So Janway lesions are non-tender erythematous hemorrhagic or pustular lesions often found on palms and soles, seen in infective endocarditis. So these are the Osler's nodes, this is tender or subcutaneous nodules. These are the subconjunctival hemorrhages seen in infective endocarditis. This is a photograph of splinter hemorrhages. So Roth spots, these are white centered central retinal hemorrhages that are considered pathognomic for subacute bacterial endocarditis. There is central retinal, wide-centered central retinal hemorrhages like this. The pathognomic of subacute bacterial endocarditis. Coming to the modified Duke's criteria for clinical diagnosis of infective endocarditis, I'll just brush through the important points. Positive culture, typical for organism for infective endocarditis, on two separate blood cultures: Viridin streptococci, Streptococcus galloliticus, Hasse group, and Staphylococcus aureus, or in community-acquired enterococci, or persistently positive blood culture defined as recovery from a microorganism consistent with infective endocarditis. Blood cultures drawn should be 12 hours apart, all of three or a set of more than 4 separate blood cultures, with first and last drawn at least 1 hour apart. Single blood culture of Coxiella bruneti. Then second one is evidence of endocardial involvement by positive echo or new valvular regurgitation, increase or change in pre-existing murmur. These are some of the important points to be remembered out of modified Duke's criteria. Minor criteria is predisposition, heart conditions or injection drug use, fever greater than 100.4 degree Fahrenheit, vascular phenomena like major arterial emboli, septic pulmonary infarcts, mycotic aneurysm, intracranial hemorrhage, conjunctival hemorrhage, Janeway lesions, immunologic phenomena like glomerulonephritis, Osler's nodes, Roth spots, RA factor, microbiologic evidence, positive blood culture but not meeting the major criteria, or serologic evidence of an active infection of an organism consistent with infective endocarditis. This is a minor criteria. Coming to antithrombotic therapy in infective endocarditis. So infective endocarditis with mechanical prosthetic walls, infective endocarditis, coronary artery stenting, time-limited dual antiplatelet therapy followed by aspirin indefinitely. Infective endocarditis with atrial fibrillation with CHA2DS2 score more than or equal to 2. Anticoagulant therapy is indicated. Infective endocarditis with atrial fibrillation with mitral stenosis regardless of CHA2DS2 score. Anticoagulant therapy will be indicated in these conditions. Extracardiac complications of infective endocarditis. One is mycotic aneurysm. 2 to 5% of endocarditis patients, about 50% of these cases involve cerebral arteries, presence as headache, focal neurological symptoms or hemorrhage. Cerebral hemorrhage could be monitored by angiography. Management: some will resolve with effective antimicrobial therapy. Surgical therapy is required for aneurysms that persist, enlarge or leak. Extracerebral aneurysm, patients present as local pain, mass, focal ischemia or bleeding, managed surgically. Splenic abscess, 3 to 5% of patients with endocarditis. Management is image guided percutaneous drainage or splenectomy. Indications of prophylactic antibiotics in infective endocarditis. Dental procedures. Risk of infective endocarditis is generally highest for dental procedures that involve manipulation of gingival tissue or perforation of the oral mucosa. Example: tooth extraction, drainage of a dental abscess. Prophylaxis is not required for dental procedures like placement or removal of prosthodontic appliances, placement or adjustment of orthodontic appliances, routine anesthetic injected through non-infected tissue. High-risk cardiac lesions in which endocarditis prophylaxis is advised before dental procedures. One is prosthetic heart valves, prior endocarditis, unrepaired cyanotic congenital heart disease including palliative shunts or conduit, completely repaired congenital heart defects during the 6 months after repair, incompletely repaired congenital heart disease with residual defects adjacent to the prosthetic material, valvulopathy developing after cardiac transplantation. It is indicated in certain respiratory tract procedures like tonsillectomy, adenoidectomy, and bronchoscopy with biopsy. Skin or certain soft tissue procedures. Patients undergoing surgical procedure for management of infected skin, skin structure, or musculoskeletal tissue should receive prophylactic antibiotic therapy. Prophylactic antibiotics are either cephalosporin or vancomycin. Patients cardiac surgery with prosthetic material. Patients undergoing surgery to place prosthetic heart valves or prosthetic intravascular or intracardiac materials should receive prophylactic antibiotics. Most commonly used antibiotic for this indication is cefalozolin, which is 1 gram IV stat.